Good afternoon, everyone, and thank you for joining us for today's webinar. We are going to get started here in about 8 minutes, but before we do, I would like to go over a few housekeeping items with those of you that we have gotten into the room. For those of you that have just joined us, the first thing I would like to make mention of is our chat pod, which is located on the left-hand side of your screen marked chat. We are utilizing our brand new platform, so some things might look differently, but we wanted to make sure that the chat pod was easy to find, so we put it in the same exact location as it's always been. This chat pod will, as always, be the best way to communicate with us if you have any questions regarding today's material. All questions pertaining to the material will be retained until the Q&A session that will be held at the very end of today's webinar. So please feel free at any point of today's discussion to go ahead and type in your questions there in the chat pod, and we will house them in our Q&A cache, and then we will get them answered during our Q&A session that will be held after today's presentation. This chat pod is also the best way to communicate with us should you experience any technical issues. If you do have any technical issues, please make sure to let us know there in the chat, and either myself or one of our customer service representatives will make sure to get you taken care of. All of your audio for today's webinar is going to be streaming through your computer speakers. So if you ever have any issues with your audio and are not able to hear, please make sure your audio's speakers are turned up all the way. And again, if you do experience any technical issues with your audio, please let us know in the chat. Just some things that we have found out with our new platform. The best web browsers to utilize are Google Chrome and Firefox. Those are going to give the best user experience. So if you do have any issues with either seeing the live feed or hearing the audio, the best thing to do is to switch to one of those browsers, as those will give you the best user experience during today's event. Safari will work as well, although some of the older versions of Safari do have some issues playing the audio. So again, Google Chrome and Firefox are going to be the best web browsers to utilize for this event. We've got about 6 minutes before we get started, so before we do, would like to find out just a little bit more about our audience and to make sure that the chat pod is working for you. So if you wouldn't mind taking a few moments to go ahead and type in your location there in the chat pod, that'll give us some great information and feedback about today's audience, as well as just what kind of reach we are able to obtain with our events at the FTCOE. Again, we do have about 5 minutes before we get started. I'm going to mute my line. I'll come back on here in just a few moments to go over housekeeping with those that come into the room over the next few minutes, and then we'll be getting started here at the top of the hour. Thank you for joining us today. Good afternoon, everyone, and thank you for joining us for today's webinar. We are going to get started here in just a couple of minutes, but before we do, I would like to go over a few housekeeping items with those of you that have just joined us. For those of you that we do have in the room already, the first thing I would like to make mention of is our chat pod, which is located on the left-hand side of your screen marked chat. This is a new platform that we are using, but we still have the chat pod over on the left-hand side of your screen. This chat pod is going to be the best way to communicate with us should you experience any technical issues throughout today's webinar. If you do have any technical issues, please make sure to let us know there in the chat pod, and either myself or one of our customer service representatives will make sure to get you taken care of. This chat pod is also the best way to communicate with us should you have any questions pertaining to today's material. Any questions pertaining to the material are going to be retained, and we will use them at the end of the event during our Q&A session. So please, at any point of today's talk, feel free to go ahead and type in your questions there for our subject matter expert, and we will hold them until our Q&A session at the very end. All of your audio for today's webinar is going to be streaming through your computer speakers. If you do have any technical issues with the audio, please make sure to let us know there in the chat pod, and we will be sure to get those issues taken care of. Some things we have learned with our new platform is that Google Chrome and Mozilla Firefox are the best web browsers to be able to view and listen to today's presentation. Some newer versions of Safari work as well. So please make sure that you are utilizing one of those web browsers to ensure the best experience possible during today's webinar. Again, if you do experience any technical issues, just let us know there in the chat pod, and we will be sure to get you taken care of. As with all of our other webinars, we always like to find out a little bit about our audience from the beginning, and we also want to make sure that your chat pod is working properly for you. So if you could take a few moments before we get started to type in your location there in the chat pod as others have done before you. That'll give us some great feedback about our audience as where you are coming and joining us from today. It will also ensure that your chat pod is working properly, and will show us just what kind of reach we are able to obtain with the FTCOE. It is almost the top of the hour, so I'm going to mute my line here in just a moment, and then we will get started here shortly. Thank you for joining us today. Good afternoon, everyone, and thank you for joining us for today's webinar. My name is Josh Vickers, and I am with RTI International's Forensic Technology Center of Excellence. Today's webinar is entitled A Therapeutic Response to Suspected Elder Abuse. Our subject matter expert and presenter today is Dr. Pat Speck. She graduated from the University of Tennessee Health Science Center College of Nursing in 1982 with her bachelor's, then in 1985 earned her master's and her doctorate in 2005. After retiring from UTHSC College of Nursing as the DMP Public Health Nursing and DMP Forensic Nursing Concentration Coordinator, she joined the University of Alabama at Birmingham School of Nursing in the Department of Community Health Outcomes and Systems. Currently, Dr. Speck is a professor and coordinator of the Graduate Advanced Forensics Nursing Program of Study. She experiences international recognition as a board-certified family nurse practitioner and expert in advanced forensic nursing care of patients, experiencing an intersection with the legal system. She consults with the Department of Justice as a subject matter expert in forensic nursing and evidence, with universities desiring forensic nursing curriculum, nursing specialty organizations desiring consensus and curriculum in forensic nursing, and internationally in Africa, Eurasia, the Caribbean, and Central, South, and North America with governments, universities, institutions, and non-governmental organizations to evaluate and implement infrastructure change in coordination community response to victims of violence. Just a quick disclaimer, the opinions, findings, and conclusions or recommendations expressed in this presentation are those of the presenter and do not necessarily reflect those of the Department of Justice. Any products and manufacturers discussed are presented for informational purposes only and do not constitute product approval or endorsement by the U.S. Department of Justice. And now, without any further ado, I would like to go ahead and hand the microphone and floor over to Dr. Pat Speck. Dr. Speck, if you want to go ahead and share screens and bring up your presentation.
I guess I have to learn to walk and chew gum at the same time. Good afternoon. Today we're going to talk about caring with knowledge and a therapeutic response to suspected elder abuse. The reason we have this topic is because of some epidemiology. So I'm going to forward slides, and of course, like anyone else, I want to recognize collaborators throughout my professional career who have contributed to much of what I know about older person abuse, assault, and exploitation. That includes Diana Fagno, Dr. Jenny Lacoste, and Dr. Stacy Mitchell. I also want to tell you there's no conflict of interest unless you count federal funding and family business ownerships, including patents. The views and opinions are those of these authors, and I am the author today. It doesn't constitute any reflection on the Department of Justice or Research Triangle Institute or the University of Alabama at Birmingham, my employer. So while we strive to make the information timely and accurate, authors make no claims, promises, or guarantees, no warranties, especially in respect to the contents of this virtual presentation. So reference in this presentation to a commercial product. This information is for your convenience as public, and it doesn't constitute an endorsement by me, a recommendation, or any other promotion. So the photographs that I use are from Creative Commons or government websites, and they're for educational processes only without intent to harm the copyright holder. So when I look at copyright and permission, this actually, because I am an employee at the University of Alabama School of Nursing, the presentation belongs to them. I would expect if you want to use any or part of this that you get written permission from all the authors. There is a recording today, and the information contained herein is available with the lit search. We invite future forensic nursing students to study at the University of Alabama School of Nursing. Any cases that are mentioned today are from my experience and my practices. They may represent a similar situation in yours, but because I tend to conflate and confound and de-identify, they are modified to protect the individual person. So it is your professional responsibility to take the information that I bring today. If you're a licensed professional, it's up to you to seek out and understand and implement the best evidence. And these authors and presenters, which is me today, assume no responsibility for your interpretation of the material or the application to your practice. So I'm a healthcare provider licensed with standard of practice. The presentation has loads of evidence-based suggestions supported by literature, and it's for all who actually encounter an older person needing our help. And in this case, we're looking at elder abuse. So I've got some objectives for you, and those objectives include understand the epidemiology, to describe and recognize the older person's vulnerabilities, and to take the pearls about how to approach an older person that is suspected to be a victim of abuse. Understand that they have legal rights. They have capacity for independence. They also have competency unless removed by the court. And identify and locate state and local supportive agencies. And I've got several slides for you with lists available. So let's talk about the world. And the world is aging. Epidemiologic studies say by the year 2030, that's an important demographic turning point in U.S. history. The U.S. Census Bureau says that all baby boomers born from 1945 for 20 years will be older than 65 years old. This expands the size of the older population so that 1 in every 5 residents will be retirement age. So when I talk about elder abuse, I'm speaking about anyone who is 60 years or older, and that's because the federal government defines it that way. But let's look at another view of how the population of older persons will look by 2060. So in 2060, you see there's 2 pyramids. In 1960, at the tip of the pyramid, it looked like a rocket. So in 60, if you look at the smaller numbers between the 20 and 35-year-old, that is actually World War II. So in 1960, if they were born in the 40s or in the 20s and fought, they're now in the 40s. And you see this kind of hourglass shape. Bottom line is, in 60, most people did not live past 85. They're predicting in 2060, however, that the population is going to grow and it's going to cross the 400 million threshold, up from 326 million. So an average, it's going to grow by an average of 2.3 million a year until about 2030, 10 years from now, and then it's going to level off at 1.9. So this falling birth rate is part of the reason the pyramid that was on the left in 1960s will be inverted in 2060, and in 2080 more so. Part of that has to do with the infertility rate worldwide, which is about 50% of males are infertile now. So let's keep looking. Approximately 1 in 10 will be 60, have experienced some form of elder abuse. And so if one study estimated that only 1 in 14 is going to be reported, and so you have to look at what their vulnerabilities are, beginning with their health and extending into financial and living status, life experience. Their life experience is such that as they age, they have diseases that affect their cognitive status and living situation, their physical abilities and physical relationships. So a gradual change in that physical relationship is predicated by the body changing. And the body's changing because the hormones that supported reproductive health are no longer there. And so what ends up happening is older men and women begin to look alike. Men have breasts and central adipose or fat around their middle, and women have the same thing. Their breasts shrink and lots of fat in the middle. So when they look alike, you think, oh, well, they're no longer sexual. Well, then nothing is further from the truth. So let's understand some of the 5 senses: touch, vision, taste, smell, and hearing. They're all affected by the aging process. All the providers have education that teaches about aging changes. And so in this presentation, while I'm going to have a healthcare provider view, this information is good for whoever you are if you work in the public and encounter older persons. But it may be new for some, so let's start with the notion that there's a skill in communicating with that older person. I think it begins by understanding the aging process and using therapeutic approaches to help elders make good decisions for their health. And I'll talk more about that as I go through the slides. So let's talk about vision. Presbyopia is vision loss. It occurs in the average person around 40, and by 45 for most, they'll have to wear at least reading glasses. The peripheral vision decreases and worsens even after 65, and distance vision worsens. And for those with sun exposure, cataracts can cover the lens and diminish clarity of those visual fields. So these deficiencies occur most often in women, but they also occur in men. When working with an older person, you have a magnifying glass for written words because they're not going to be able to focus as easily. And if you have a very bright room with a glare, they're going to have more trouble. If it's too low and then it goes to a highlight, the adaptation is going to be problematic. So in addition, they have a depth perception problem, and depth perception puts the older person at risk for falls when moving from a light area like outside into a darker office. So taking care to assist them, particularly if there are changes in floor elevation, will help that person adjust, particularly if they're at risk for falls. So think about this, that if they're having difficulty reading something you gave them, it's likely they're going to want to be agreeable. So they may not be able to read the fine print, but they won't tell you either. So likely you're going to have to read fine print to them. So loss of appetite's a problem too. Things just don't taste as good. When people make poor nutritional choices, the gut is not as good at absorbing nutrition. So when you have a lack of taste, then you have food that doesn't taste good, and then you don't eat as much. All of this weakens the immune system and could result in their death, particularly if they live alone, eat alone. And so if eating is no longer pleasurable, why should they do it? Another symptom of the loss of taste is a propensity toward foods that are hot or heavily spiced. And in those individuals, they may have more gut reactions. So another thing that happens is they're not as thirsty. So if they become dehydrated, then you might find that they are confused, have difficulty walking, they're dizzy, they may have headaches or dry mouth, even sunken eyes, no sweat and no tears. Well, the heart's going to try and circulate that fluid, and so it's going to speed up. And the blood pressure, their hands are going to be cold, they're going to be clammy. And so slower indigestion and infrequent going to the bowel break, or with women, more incontinence and men, then this basically is a setup for chronic urinary tract infections, and that is one of the top 3 killers of elder people. So olfactory decline. So going along with taste is the nose. And part of the problem is that if you can't smell your food, you can't think it tastes good. So I will tell you, you always know this person who is nose deaf because they always wear too much perfume. About 30% of men and women have problem with their sense of smell, especially after the age of 80. So if they don't detect the odor, they can't know that the leakage in their pants smells like urine. They can't know that the garbage in their home smells like trash. And then self-neglect becomes a real issue. So what am I doing here? I'm absolutely moving toward describing what is normal aging versus what is abuse. So let's talk about touch. Older persons love to be touched, but sensation, that kind of loss of sensation is important because their skin is dry, it's less elastic, they don't have hair where they used to, so they don't have an anticipation of touch. Most people are cold intolerant, which is why many move to warmer climates when they retire. And so when we encounter a person who has these old age symptoms, It's important for us to document them, to recognize them first, then document them and describe them so that we can understand the difference between pressure ulcer that is neglect and ulcers that are not, that are more disease focused. Of course, heat stroke and burns and hypothermia are all important symptoms to determine if that is associated with the delirium or dementia. So when we get in the room with an older person and we suspect there may be some abuse or assault, we really want to communicate well. So here's some pearls for you. We want the older person to know what we're saying. So large letters help. Avoid colors from the blue end of the spectrum. And the reason is it's not seen as well. And always allow for that light adjustment that I talked about. So they're going to pick up light levels that reduce glare. And so that means painting the room where you're going to do your interviews and things in muted colors that are bright but not glaring. It's also going to ask you to use things that are familiar to that older person, especially because familiarity reflects their intelligence and their capacity to communicate. Now, what's going to be lost is that math ability if there's an early dementia. So in order to figure out if they understand distance, you may want to use things that are familiar like car lengths rather than how many feet, because that information is lost rather quickly. Another communication pearl is that not all older persons are hard of hearing. In trauma-informed care, we discussed this on the previous webinar, even our position is important to engaging the older person. So let's dispel the myths. Not all older persons are hard of hearing. They may be sensitive to loud speech. Be sure and ask them about their hearing preferences. Do you wear a hearing aid? Are you sensitive to loud speech? They often ask people to repeat information. So what is that about? It's about not processing it clearly. When they hear unfamiliar sounds, they have difficulty figuring out where it's coming from. And if they identify difficulties or you see this level of struggle, then you can help make their environment safer, which means you're building trust with that person. You'll find they're more cooperative when you consider their needs first. And for all of us in healthcare, in that patient-centered care, and if you're not in healthcare but working with elder victims, isn't that victim-centered care or client-centered care? So that's what we want to move to. We want to make sure the client is actively participating in our processes. So physiologically, what's going on? The neural activity decreases when people have uncorrected hearing loss. And what that means is the brain is not stimulated, and so they lose the capacity for language and other things. They may mispronounce words. You may have to eliminate all background noise in your office. And if that's hard to do because you're on a busy street, you might want to go to an internal office where you can communicate easier. So when the person is talking to you, look at their face, let them look at your face, let them read lips. And if they don't interpret the words correctly, make sure that you ask for feedback about what you said. Sometimes it's just as simple as wax buildup in the external ear canal. And so for healthcare providers, you have to look for that and get rid of that before you begin conversing with the person. So let's look at the complicating comorbidities that you're going to run into. We just reviewed the 5 senses, those vulnerabilities that occur because of diminished function, and whether the ability to see and recognize danger, feel injury, or even hear commands. They're the pearls about communicating with older persons. There are also comorbidities, disease states that complicate our findings in the evaluation of elder abuse, and they require a team approach, particularly if there's a persistent chronic or mental health disease. And when dementia occurs, and it's increasing, the symptoms are marked by memory disorders, personality change, and impaired reasoning. It's predicted by 2060 there will be 131.5 million persons worldwide with some level of dementia, 1 in 10 over the age of 60. In the U.S. alone, they are estimated to be almost 30 million by 2060. So we have to get good at doing therapeutic interviews with older persons who have experienced dementia. So let's look at memory. That's usually the first thing to go. What it is the ability to retrieve or recall information. Cognition refers to the sum total of all your thinking skills. It involves your memory, your executive and visual spatial judgment, your language production and understanding, how you're able to concentrate, and are you able to pay attention. The cognitive impairment, therefore, is characterized by deficiencies in any singular or multiple domains here. And dementia is that overarching clinical term that describes a progressive decline in not only cognition, but also in functional abilities resulting from the brain degeneration. So what are you looking for when you're suspecting cognitive decline? Well, some people write notes and plaster them all over the house to remind them of the tasks that are necessary to maintain their independence, like phone numbers. However, when it's a little further advanced, they're going to forget where they put their phone, or how to operate the TV remote, but they're unable to turn it on and off. They're unable to find the stations that they used to like, so they don't watch TV anymore. And of course, the result is they have difficulty planning and organizing and coordinating their activities. So then the question is it becoming a self-neglect, or is it a progressive dementia? Consequently, self-care declines, and the personality changes and language deficits diminish their ability to reason, to actually have appropriate behavior, and also when they can't get that done, it increases their agitation, and their partner might actually experience outbursts of anger. So occasionally with certain types of dementia, there are hallucinations. This is particularly true if certain parts of the brain are affected. And all of this is made more complex with mental health comorbidities or long-term drug use and abuse. So what are the types of dementia? Recognition of types of dementia and their manifestations obviously is beyond the scope of this presentation. However, there are things that you can document that you see that lead the healthcare provider toward a specific dementia diagnosis. So let's talk about the different dementias and signs. Average period from diagnosis to death is 8 to 10 years. Although brain changes may precede these manifestations that you're seeing by as much as 20 years or more. The combination of dependence on others and progressive loss of cognitive ability creates a situation where the person with dementia may engage in verbally, physically assaultive behaviors toward their caretakers. Conversely, the presence of the dementia, regardless of the type, increases the risk for formal and informal caregiver abuse and financial exploitation. So members of minority groups who are at higher risk for diabetes and high blood pressure are at higher risk for vascular dementia. Vascular dementia shows up suddenly, like after a stroke, and certain functions are lost, but also certain memory. But it can also show up slowly over years of heart and blood vessel disease. Frontotemporal dementia is a nerve cell damage caused in the frontal lobe and the lateral lobes that decrease function in these brain regions. Okay, so what does it look like? Behavior and personality, but the language is gone. So when they say a phrase, the phrase is out of context, out. When you ask them to come back, they may not be able to explain it. Lewy body dementia deposits protein in the brain, different areas, but it's thinking and reasoning. So when the reasons and rationales are there, this one is noted by the hunched posture, rigid muscles, shuffling walk, and trouble initiating movement. And a lot of times it's confused with Parkinson's dementia. So Alzheimer's disease is the irreversible progressive brain disorder that destroys memory and thinking and the ability to carry out even simple tasks. It's the catch-all phrase for dementias, but it's not the only diagnosis. So let's look at recognition and communication in that person experiencing dementia. So when a person with dementia is encountered, suspected of being a victim of or an offender even, it'll take long to tell what happened to them or what they did. Be sure to speak to them as you would any other adult. Even in the dementia, they have the capacity to decline your care until that is removed by the court. Expect that they'll be easily distracted, and when fearful about anything, they're going to be resistant. They may be paranoid, and they may deny all information. Trauma-informed care accepts the choices they make and helps reorient the person to the process that you're trying to lead them through. An important pearl for all, remember that the memory is moving back through time for many of the dementia disease diagnoses, and particularly with progressive dementia, their response to the question you ask may actually reflect a previous experience in their life and not the actual experience that they encountered today. And that's because their memory is faulty. So my colleague at the University of Alabama at Birmingham School of Nursing, and she's an expert in dementia care, Dr. Rita Jablonski, she helps caregivers overcome the resistant behaviors. And as she explains, and this is key, resistance is related to a fear. Break through that particular fear they have, and there's cooperation. And then she says, well, most of the time. So I encourage you to look at her blog, and that is Make Dementia Your Bitch. She has wonderful opportunities for caregivers and responders alike to learn how to address a person with dementia. So the best assessments include trauma-informed care principles. It's about the person, whether they're a victim or offender, and you are there to help. Understanding that functional decline in cognition helps determine their capacity and therefore their ability to cooperate and participate the process without oversight. In courts, on the other hand, they determine competence. They're lenient with adults and their liberties, that is, until they become a danger to themselves or others. So in particular, first responders and nurses and physicians, they have methods to improve relationships with their patients through the provision of safe, transparent, and predictable processes using reassurance and rewards that normalize all their responses, whether they're normal or not. This slide has a list of trauma-informed behaviors to use. Okay, it's attention to surroundings and lighting, speaking to the person, not too loud, not too soft. Face them. Wait. Listen twice as long as you talk. They have to have the time to process. Reassure them with re-understanding and normalize their responses, even if they're making obvious errors in word use. So if they ask you to tell the statement over and over again, do that over and over until they understand what's happening. What you're experiencing in their responses are symptoms of their disease. And your documentation can help determine the person's competence to live independently, knowing full well that their capacity may decline that prevents them from driving a car or maybe even handling their money, but not the activities of daily living where they bathe and dress and feed themselves. These functional declines create a vulnerability to those looking to abuse and exploit. So medical folks, they're going to go through all of these diseases and tests, and we're going to try and find the answers that make more complex the person's um, point in life. Where are they with their health, their diseases? What are they able to do? Is there a disease that we can correct, cure, or manage that's going to give them a better quality of life? So laboratory tests are listed here, and these are some of the more common ones. One that I did list, hydrocephalus. Unlike in a baby where hydrocephalus is acute, in older persons it's insidious. It occurs over time, and once corrected, they become themselves again. So if they're prescribed medication, the two big ones, anticholinergics and benzodiazepines, to calm their anxieties, I'm telling you, this will make them nuts. So be aware that medication, metabolic diseases can affect that person. So we've been talking about capacity and competency, and there is a difference. Capacity is that judgment of the clinician. Can they perform a specific task? Is it a functional task? Can they do it? Can they consent to health care? Can they consent to sex? Can they change their will? Competency is that legal term. And that legal term, a person is presumed to be mentally and physically capable when properly advised and assisted of understanding that advice and making decisions regarding their important matters. When they're determined competent, that's through a judicial proceeding. Now let's look I'm just going to go through a list. The financial management, treatment consent is narrow, testamentary capacity, research consent is narrow, sexual consent is narrow. Voting, that's a cognitive task, and it's very narrow. So the courts are not going to take away a person's right to express their activities in this country. So let's look at the summary. It is aging changes that are declining for all. They're predictable. And these things that hasten aging changes, and in our family, we have a saying about family members who were rode hard and put up wet. And that refers to the horse that's worked to death and then they're not taken care of at the end of their workday. And when that happens, it speeds the aging changes. We talked about that in the last webinar. The speed of the decline is directly related to the physiologic reserve from living well without stress. And it's according to Selye, stress has the potential to create the disease and shorten the telomere burden that gives you longer life. So we know aging creates changes in the physiology. Infection increases inflammation. End organ damage, it results from surgeries and injuries. All combined, they address subclinical diseases that end the quality of life, and then ultimately they end life. So if there's early enough stress in the life experience, the epigenetics changes occur, again discussed in the last webinar. You may have a lifetime of stress, and then you may die sooner than you would have had you had a lifetime free of most stresses. So where are the older victims? The ones in my clinical practice have been in hospitals and assisted living and group homes and in their own homes and apartments, condos, and rentals. I think that offenders find victims wherever the offender is, and they look for the vulnerability. So this physical sexual neglect, exploitation occurs wherever the offender is. And there are persons who do not realize, and this is the person, the family member that doesn't realize their responsibility to a vulnerable older person, again, made more complex if that older person has capacity. So who perpetrates it? Family members, caretakers, neighbors, friends, attorneys, banks, and other institution and healthcare providers. So remember, the vulnerability is the signal for the offender to set up the crime. And I think that's, if I can only leave you with one thing, is people who will do the criminal activities against older persons plan it and execute it with the vulnerable person that is available to them. So, since caregivers are the primary suspects, let's look at the epidemiology. 15 million Americans provide unpaid care for their elders. They make daily sacrifices. They call it ambiguous loss. The person is still alive, but they're not with them. The dementias, the diseases take them away slowly. So what happens is they're going to have physical problems, emotional problems. They fail to take breaks. They don't want to ask for help. They don't want to be seen as weak. And they eventually lose their friends. I'm going to tell you the stress of caring for a person with dementia is significant. And for some, the caregiver's death precedes their parent or spouse. So when should one suspect elder abuse? Well, unexplained bruises, cuts, burns, strains, bed sores, frozen joints, unexplained venereal disease, genital infections, bleeding and tearing in the genital area, sudden changes in behavior, particularly when the abuser is around. And if they're in an institution when the staff refuse to allow open visitors, then that's a red flag. So suspected if residents being kept over-medicated, if there is a loss of their possessions in an institution, or their bank accounts go to zero without any explanation about whether it went to care or to whatever. And any abrupt changes in will or other financial documents. So when you're investigating and seeing these symptoms, a team should come together and gather and share information about their findings and their dependencies on each other for information. This is a difficult practice to overcome because the roles have limits about what they can share. I'm going to talk about that later in the presentation. So, if abuse is suspected, there was a great little study by the Chicago Health and Aging Project. And what they found out was that the relationship between the disease and trauma was significant. And what they found was abuses experienced by older persons included sexual abuse, emotional abuse, confinement, caregiver neglect, deprivation, financial exploitation. And guess what? They died sooner. So if you think about that and what it means to the older person's long life, that identifying and stopping abuses before they can devastate the older person's finances or health is what our charge is as healthcare providers, as teams who address the needs of the older persons in our communities. So if a nurse suspects abuse, it's important to consider elder assault is associated with more violent acts. So what we may see are subdural hemorrhages, eye, nose, and mouth injuries, particularly that are likely non-accidental, contusions of lips, cheeks, soft palate, face fractures, missing hair, particularly in odd places, not where you'd expect to see balding, bruising, skin tears. So common injuries not seen in younger persons are subdural injuries after head trauma. So just a simple shake back and forth may dislodge the brain and cause the capillaries to bleed. These kinds of contre-coup are predictable and need certain tests done in the hospital. So what happens if they fall and bump their head? Well, it's the same thing. So certainly restraint of an older person is something that all healthcare providers are moving away from. But if there is injury to that older person that's being restrained in a wheelchair, for instance, you'd look for friction burns and different kinds of bruising and skin tears. So there's lots of symptoms of suspected assault. Let's look at the mortality. I know it's more epidemiology, but it's really important for us to understand that when any study of abuse occurs, the important epidemiology looks at morbidity, mortality. Who dies from this? Who ends up hospitalized or in a nursing home? And we found that with abuse, it's 13.49 deaths per 100 years. That's higher than the 5.9 deaths per 100 years of persons not abused. The persons who end up in nursing homes, things like that, 18.33 deaths per 100 years, much higher in the first year after the abuse. So if a person is older, and of course the older they are, particularly in the old population over 90, assaults usually result in their death. I've said this multiple occasions. Prosecution needs to look at that as a contributing factor to death and minimally should be a manslaughter. The latest federal statistics about state-based adult protective services looked at 713 investigations, and they confirmed over a third of them, where 10% of the abuse victims counted were under the age of 50, and these are the vulnerable adults with disabilities. Financial abuse is a big deal because wipe out the family finances, and you see the older person becoming dependent on other resources. When this happens, the abuser uses the resources of the older individual for monetary or personal benefit. Now, I'm going to also explain that in the most difficult cases, when there are multiple children, squabbling between siblings who claim a financial abuse by the child caring for the elder person, they have difficulty proving that in court when there is care provided and the resources are used for that direct care and supplies. It's very hard when there are limited resources to have the amount of equipment, resources necessary to care for an older person that is dependent. Our health system, and in particular home health, does not have all the resources necessary to assist. So in an investigation, one needs to consider that also. And when provided, does it actually improve the health of that older person who is dependent? So there's types of financial abuse. Here's a whole list of them: lottery, sweepstakes. There's technology scams and predatory lenders too that prey on elders, trying to get them to withdraw money and send it to them. But you know what? Caretakers and friends and family, they take the bank cards and use them. They may take a loan out in the older person's name. At any rate, the banks are aware of this, and they're making changes, and they're reporting, and investigations of financial abuse occurs. Again, it takes a team to assist in that investigation. So there's some things that are really obvious. And the first one is to believe the older person when they complain, and believe them all the way through the complaint when all of the evidence is in. Their perception is just as valid, even if they have dementia. It just might have occurred at a previous time. So these are symptoms: financial abuse, sudden unjustified selling of property, missing stolen property, radical changing and handling of personal finances, and complaint of theft. So the actual resident in a nursing home will say, my stuff is missing. And we need to pay attention to that, in particular in units where people have capacity but may have functional decline. So the impact of elder abuse And financial, obviously, the impact is the same. It's loss of trust, increased skepticism and fear, shame for making the decision to give the money to somebody they didn't know. So the bottom line is they become dependent on government assistance. There's psychological abuse, the most common type of abuse, and it comes with all kinds of mental anguish and depression, isolation. You can't tell someone that your daughter is doing this to you or your son because it is your child. And of course, we're looking at what that is. Harassment and scolding, insults, degradation, oppressive atmosphere, including things like taking a walker and put it out of reach, taking glasses so they can't see, not providing oral care, interfering with decision making. All of it is a controlling behavior and it's emotional abuse. So the symptoms are fear, agitation, behavior change, behavior patterns change, unwillingness to communicate, because if that person is sitting in the room when you're doing an investigation, it might influence how they talk about it. Also, disorientation, moving an older person from the environment which they live will have a level of confusion to it. So we have sexual abuse, and it's women are primarily the victim, but is that because men don't report? Because they're raped too. Most are assaulted in their homes or the home of the offender. So they get lured into a vulnerable situation. 12% of sexual abuse occurs in residence. 15% of that is in sex offenders' homes. Women are 6 times more likely. Only 30% of the victims report, and they may not report the elements of the sexual assault that are distasteful, shameful, or just not in their sphere of an activity that was sexual. So when we look at the incidents here, more epidemiology, 83% reside in institutions, 27% in the home, 80% of the time the perpetrator is known by the person. 76% of the time their incidence is witnessed by someone else. And then in 67%, abusers were members of the family. What are the symptoms? Well, and this is an area I specialize in. We all know that it's more common than people realize. And in any given year, 11% of the elders having experienced at least one form of maltreatment. It's understudied. So let's look at what the symptoms are in rape, and that is blood and staining in the clothes, on the sheets, bruising or handprints on the buttocks or breasts, inner thighs, unexplained pain when walking or seated, of course, STIs. So when we look at that as a healthcare provider, I have to look and see what are the mimics of sexual trauma, particularly if the person is not believable because they don't have competence or capacity. So we look for bleeding and excoriation that's a result of low estrogen, uterine prolapse, cystocils, rectocils, infection, altered vaginal pH, friable genital tissue related to conditions or disease processes, excoriation from incontinence and failure to keep the area clean, anal fissures from constipation, bleeding, and inflammatory bowel disease, trauma from usual care in a nursing home like Foley catheter or perianal care. So when physical abuse is part of that, injury is also in my wheelhouse, and we begin to look at where the injury is. So it's easy to see in this photograph. Are you willing to report this? What if she tells you she fell against something and her glasses created that injury? If the person who slapped her was someone close to her, I'm sure that they're going to try and cover that event up. Slapping, hitting, beating, overall, the person examining this person must undress the older person to find the extent of the injuries. Plus, there needs to be an extensive workup of blood indices, maybe old fractures, things like that. And that's when we'll figure out, is this in fact an intentional injury? Of course, physical abuse includes wounds and cuts and broken bones and unexplained injuries, restraint injuries that are pretty classic and patterned, and particularly pay attention when there's a complaint by a resident. And of course, we did talk about the constitute, and here's a great example. I want you to focus on the first skull leaning forward and the red in the back of the brain. And as the brain goes backwards, the fall that is on the back of the head will create bleeding in the front of the brain. Now, why is that? Because the brain is free in the skull, and it is smaller, and there's more opportunity for it to slosh around with falls. One of the classic symptoms for this constitute injury is going to be a quick deterioration with brain fog, unable to think or speak, and in particular, the injury rapidly progresses into a deteriorating state without any intervention. So it's very important that the brain get the care it needs after a fall. So some will weather the fall, and others will cascade into strokes, heart attacks, blood supply diminished to the other organs, and then what happens is a fall can create death in an older person, particularly an old person. So what is neglect? Neglect is going to be defined as failing to attend a person's medical, hygiene, nutrition, and dietary needs, maybe not giving them the medications they've been prescribed, not changing bandages on time, not bathing, grooming, dressing, or just don't provide enough food for them to maintain health. That's a physical neglect. There is emotional neglect, and that is that they cause emotional pain and distress. They belittle, they infantilize the adult, especially if they have incontinence. This includes also neglecting or discounting the emotional well-being or the feelings this person has. Of course, abandonment is always a problem. We used to have older persons abandoned at the emergency department, and we know how to help them, but if they can't tell us who they are and where they live, then they become a ward of the state and go into the system. So you can see that there are different types of other kinds of neglect, financial and self-neglect. Self-neglect's interesting because we see that on TV with hoarding. We see that also self-neglect that where a person chooses not to be treated at the healthcare provider. They choose to maybe not change clothes, those kinds of things. And it's hard for us to accept, but it is reversible, and it's reversible with support, and it's reversible by understanding that we have, by constitutional rights, the right to self-determination, unless the court says we're not competent to make that determination. So, behavioral signs, here's some: fear, anxiety, withdrawn, refusal to communicate, suicide attempt, psychosomatic ailments, stomach aches, headaches, flinching when you're going to touch them, don't want to be touched, difficulty sleeping, and nightmares, particularly return to the terrors that children experience. So self-neglect's a growing concern. There's a fella in the north central area of the country, Dr. Dong. He's amassed a tremendous amount of evidence that is predictive of early death when there is self-neglect. This slide here has a list of abusive and neglectful experiences and symptoms in older persons. The next slide will continue these symptoms. So the question is, for those of you who are charged with a therapeutic intervention, abuse and neglect is not as obvious as you think. Unless the older person, I had a case where the older person was locked in the garage storage room placed on a plywood board with a plastic barrier on the board. The son hosed her off daily, twice a day, and he said, "I'm keeping her clean." I think what you have to understand is he didn't see that as abuse. It took a police officer taking pictures, bringing pictures to the scene and to the team who actually were able to address the injuries. They placed her in a nursing home and she rapidly improved, cognition returned. So let's look at some more. Emotional abuse is difficult to assess, but there are danger signs and symptoms in observable environments. So they're noted on this slide. And if you have you noticed that these things start to create a pattern, that it's not just a behavioral change, it's not just oppression. This happens with all kinds of abuse and neglect. The question is how do you tease it apart? And one of the ways you do that is you have teams address this. So let's look at the provider's decision tree. And first of all, you have to make sure the patient's stable. The obvious signs and symptoms have to occur to make a reasoned clinical decision. So first we have to evaluate the stability, the injury, the type of injury. Once stable, then we can begin to develop cognition and evaluate the capacity and competence. And using the biological, psychological, social elements, we see how a medical provider can put this case together, particularly if they have medical forensic training. So after determining the cognition, the medical history, the comorbidities, the medications, you got to know what that patient is going to tell you. I can tell you that they're going to have a great memory for what happened 20 years ago, but they're not really good at remembering what they had for breakfast. So do you have access to that primary provider? Do you have access to family members? What do they say? What are the steps that you need to take for taking care of medical steps first, then reason for the visit, then exploring the experiences and concerns. And then when working with your team, make that informed and collaborative team decision about needs and supports available in the community. It's important to helping that older person gain that independence again if it's possible. So let's look at the types of organizations that were identified in Memphis before I retired from the University of Tennessee and came to University of Alabama at Birmingham. I'm going to tell you that Dr. Wayne Pitts at the University of Memphis, along with many organizations in the community of Memphis, got together under a Department of Justice grant, and they identified all of the sources where reported elder abuse occurred. And they came up with 5 systems. There was health care, probate courts, law enforcement, adult protective services, and community agencies. Now, when we were able to identify all who wanted to be helpful in the community coordinated response to elder abuse, what we found is there was so much going on and a little duplication. And in some areas like healthcare, there was a tremendous gap in services. I will tell you that grant ended, but not without a significant amount of publicity around the needs in the community of Memphis and Shelby County. So what happened is under that grant, and I will tell you, Patty Tosti, who was the project manager, now works for Adult Protective Services as a evaluator of elder abuse. We found out through the identification of these resources that there were really 2 approaches to the elder abuse. First, it started with the community. Who logs that call? Who works 8 to 4? Who's involved in advocacy in courts? From the slide you see there are a variety of organizations involved in the first tiered response. The information comes in and they begin to put the puzzle piece together as a community. And what it looks like is that when it is a concern, but not an outright criminal act, when your first tier is available, You weigh the complaint and you develop a system that encourages advocacy groups to begin their interventions with the family and with the individual. I want you to look how advocacy, community support, and service identification in the figure outweigh an investigation of law enforcement and the healthcare response. Now, you go to the next tier, and they've identified that it's necessary to involve an investigation, to bring in advocacy for that individual and healthcare to help sort out those issues. The community of interest in the rapid response were the investigators in healthcare, as well as hospitals and shelters. And you can see from the figure that the weight of the investigation requires immediate response available 24/7, 365 for the well-being of that older person. And what's so exciting about that is we had investigation and advocacy, but we did not have health care. The community group, took on the mantra of no door closed. There was a developmental concept that meant that all members of the community of interest not only knew about how to triage to the coordinated community response, but also what resources were available in the event that follow-up was necessary. And for the life of the grant, the medical forensic piece was the hardest to fill. And I'm not sure why, but it's like any other abuse. Hospitals tend not to want it unless it has a medical element to it. So what the process was is the formative evaluative process in 25 continued through 2011. And that's when Plow Foundation took the work accomplished to date and implemented the program. They identified medical providers and sentinel nurses in homes of older persons regularly as those who would receive the forensic training. The newer program uses a team of geriatricians and home health nurses, and the geriatricians completing the expertise necessary to protect that older population. Now, I'm going to tell you, I'm thrilled that that is still up and running with the support of the Plow Foundation. So who investigates in hospitals? So this is another area that is just, it's just out there. So if an elder's in the hospital, if there's an abusive event, the investigation is handled a little bit differently because not only do they bring in the state agencies, but the hospital also investigates. They have risk management, quality management, patient safety, compliance, and human resources, all kinds of things, including forensic nurses that are skilled in documenting the evidence of abuse or assault. For the healthcare provider, it's important to remember that the role is to document what is said and seen, and using quotes. The forensic nursing role is a small piece of the investigative pie, but sometimes it is in that documentation that the courts get insight into what happened to that older person. The comprehensive assessment from a nurse includes the assessment, a nursing diagnosis, a plan, an intervention, and an evaluation. And when done successfully, the transition back to the community occurs, and it's ethically legislated under the legislation that protects that older person's liberties. So if you witness a life-threatening event in your role today, whether it's a senior or an adult with disabilities, you dial 911. You contact the local adult protective services, and you make sure that the essentials are addressed. Even if your community doesn't have a coordinated community response, it's likely the hospital reaches out to specific organizations to take over that role. So things to look out for is disappearing with contact, bruising, welts, fingerprints or handprints, the same things I've been talking about all along. And if you see that, then it's important to report it to get that family the help they need before it becomes an abusive event. So here's a list of what to report. And of course, this is pretty much across all state and territory, but be sure and look it up under elder abuse laws. What to report is typically includes abandonment, that is a desertion. It's abuse only when it's intentional, but abuse symptoms may be investigated even if they're unintentional. Exploitation, taking something from that older person for their own benefit. Neglect, keeping things from that person that would allow them to have a quality of life. Self-neglect, the liberties of the older person have to be respected, but certainly pulling them out of that, involving family, involving agencies, is something that can happen to benefit that older person. And then anyone who has undue influence stands in a position of trust but does not have that person's best interest at heart. And when? Obviously, reports 24/7. Most states have protections of immunity if you're acting in good faith to protect that older person. So who reports in your state? In our state, the states that I've lived in, healthcare providers, teachers, mental health professionals. But guess what? Nursing home, law enforcement, public safety officers, guardians, the list goes on and on. Importantly, anonymity needs to be in every state law. And the reason is because the person does not deserve a retribution for being concerned about an older person's health and well-being. So here's a whole list of federal resources for older persons on this slide. And you can see that there are a lot of interested areas in the federal government, including post office, banks, consumer protections, Federal Trade Commission. Lots of good things out there to help community address the elder abuse problem. And yes, we are having a serious thunderstorm where I am. Okay, in conclusion, trauma is subjective, but death from trauma is not. And what we know is that elders will die from their abuses. I think generational responses differ, and it's in the context of their experience. Sometimes they just need the support to change behavior toward the older, to understand what the older person is going through as they move into the dementia. Patients deserve safety, and when it's intrafamilial trauma, I want you to know it creates more suffering for that older person. So with that, I'm going to end the presentation, say blaze on, and open it up for questions.
All right, thank you so much, Dr. Speck. We do have one question that did come in, but before we go into questions, we're going to go ahead and put that reference material back up in the chat. That way everybody has access to it and is able to download that before you leave for from today's event. So we'll put that up here in just a moment. Bring mine back up. All right, so the first question we have, Dr. Speck, is from Mark. He's asking, are there cultural differences among adults who experience dementia? Does it present the same among American Indian or Alaskan Native people as among, say, whites or blacks?
I will tell you that the research is skewed, and it's skewed toward Caucasians. And that's because Caucasians use healthcare systems. I will tell you from a biological perspective, I would suggest that the signs and symptoms of brain trauma are the same across all brains, regardless of their cultures. Does that answer your question?
We'll give them a minute just to type back in to make sure that it does answer their question. While we're waiting on other questions to come in, I just want to make everyone aware that we are recording today's webinar. We are not going to be handing out the PDF version of the slide deck. That was why Dr. Speck was gracious enough to build that resource content for everyone so that you would have a great synopsis of today's event as well as her work. So please make sure you do download that before you leave today. We are recording today's event. That way we can turn it around into our archival version probably in the next week or so. As we move through our new platform, we want to make sure that we are still producing the best content for you. Also, we want to make you aware that if you are watching today's event in a group, to send us an email. That way we can make sure that everyone gets credit for today's event. We are going to give everyone just a few more minutes to see if any questions do come in. But while we're waiting on that, Dr. Speck, I'd like to hand the microphone back over to you, just so you can give us some last words and some closing thoughts before we do move on if no questions come through.
I think I'd like to thank Forensic Technology Center of Excellence for hosting this. Given the boom of older persons in the next 20, 30 years, and the percentage of persons who will have elements of dementia, coupling with the trauma-informed care that we talked about in the last presentation, there are opportunities to be gentle with the people who are vulnerable, regardless of their age. Older persons need patience, and it's the best adage I've heard is listen twice as long as you speak. You look for the signs and symptoms of dementia. You may be surprised. It might be that they were in a serious crash and lost part of their brain years ago, and now they have difficulty with one thing or another. And they're older. So understanding their life trajectory, what they experienced, is going to go a long way to, and finding out about that is going to go a long way to help that person trust you. Okay, so I see another question. Are there efforts to address the gap in knowledge about racial and ethnic differences in what we know? Yes, there are, particularly in nursing science, caregiver science related to all kinds of disease states is ongoing and creating volumes of information. It's important to know that regardless of the disease, whether it's cancer or dementia, families go through a process of horror and fear first, fear of loss, and then it is the drudgery of the gradual demise of their loved ones. Or, for some, the recovery with correction. I mentioned two things that are correctable. One is related to the brain fluid. Once you recognize that there is increased fluid in the brain, it's easy to have surgery and drain it, and then your older person is back to the normal self. These are the kinds of things that, regardless of the racial, ethnic issues faced by patient populations, they're all going to respond the same to increasing fluids on the brain. So the key is, and I think what you're getting at, Mark, is there equity in care? And I will tell you, access and equity to me means having equal treatment when you have similar symptoms. And I will tell you, access and equity are a difficult thing to accomplish when you have disparate communities affected by social determinants of health. And I'm thinking about a rural person who may have these symptoms, but because they have been so self-reliant that they don't recognize that it's a correctable situation. And because of the lack of access and equity and care in the area, they won't get what they need until there may be permanent damage. So for that, I say to you that if you're a law enforcement officer, a family member, I've now given you a few tools to take back to your communities and to begin to talk about how to bring a person who is beginning the dementia journey into the healthcare arena so that they can receive equity and access to the best and the brightest who know how to correct these things. So it takes us all to create these inroads. And I'm not sure about all of the listeners, but I think that we all have had parents, and our parents are either still alive or they're not. And if they're not, you may have already experienced the journey with a patient, your parent who had dementia. That is true in my life, and it's also true that we've had other things that I journey with my parents about until they died. So I think that we all are going to have this experience. The question is, how do we corral the resources to make sure the journey is therapeutic and resourceful, where the child or the spouse feels good about their relationship through the journey. Trauma-informed care helps. Certainly having access and equity and care helps. And I absolutely encourage all of you to take advantage of what's available online, support groups, things like that. And if you're interested in collaborating on the development of a coordinated community response, there are Department of Justice monies that can go to communities to begin to address the need.
Thank you so much, Dr. Speck. I'm not seeing any other questions come through, so we are going to go ahead and move into our closing for the day. Obviously, the first thing we would like to do is, again, thank you so much, Dr. Speck, for your countless hours of research and dedication that you have put in to your field. You are a fantastic resource to have, and we definitely appreciate your time in presenting today.
Thank you for the opportunity.
All right, and obviously, again, we always like to thank our attendees for joining us today. Without your support and viewing, we would not be able to continue to bring you these webinars and all of the forensic information that we bring out to you on a weekly basis. So thank you very much for your attendance and your support. You will see below the closed captioning there on the right-hand side, there is a link you can click that will take you to the survey. So when we are finished here, if you wouldn't mind taking a few moments just to click on that survey link and completing that survey, your feedback is greatly appreciated and always helps us mold the way that we not only bring you content, but also what content we are bringing out to you, the forensic community. So if you could take a few moments to complete that, we would greatly appreciate it. Again, thank you so much, Dr. Speck, and thank you to all of our users and listeners. Tyler will be posting up some links here in just a few moments that will have all of the social media outlets that we currently have, such as LinkedIn, Twitter, and Facebook. So make sure that you follow us on those outlets if you are not doing so already. We will also be posting links to our podcast as well as our website, where you will find all of our no-cost offerings, such as podcast webinars, symposiums, and reports that we are constantly putting out to you, the forensic community. Again, thank you everyone for attending, and we look forward to seeing you in our next webinar. Have a great day.
Recording has stopped.
Okay, how was that?
All right, that was great, Dr. Speck. How are you doing?
I'm just thinking that could kill my fax machine for going off. Just talk about irritating me.